Hello, and thank you for inviting me to give this talk about the bladder care and symptoms and how to manage the bladder and looking at different treatments and appliances at your conference. It is a great honour for me. My name is Dr. Sarah Wright, and I am the Uroneurology Fellow at Queen Square at the National Hospital for Neurology. I'd like to give thanks to Dr. Panica and Mrs. Colette Haslam for providing some of the slides in preparation of this talk. Now, I'm just going to turn my video off whilst I continue with the slides, and I look forward to at the end having the video back on and we can answer some questions as well. So why do we talk about the bladder and why is it important? We know that bladder dysfunction is common in men and women with ABCD1 gene for X-linked adrenoleukodystrophy. And this is a piece of research that Dr. Panica performed several years ago, and some of you may have been involved with this research. So what we know is that men with AMN and female carriers commonly have bladder symptoms. And in fact, female carriers of the gene have as severe storage bladder symptoms as men with AMN. And we can see here that overactive bladder symptoms, which is what we describe as urinary urgency, urinary frequency, and urge incontinence, is occurring in at least 85% of women and 100% of men. Stress urinary incontinence is more common in females compared with males, but is still high for both groups. A more recent paper again looked at urinary symptoms in X-linked adrenoleukodystrophy, and this really confirmed what the previous research had shown, in that urinary symptoms are very common. And in fact, at least 75% of men and women had at least one urinary symptom. And they were either, or more commonly, urinary frequency, urinary urgency, and urinary incontinence. So again, those overactive bladder symptoms. What was less common was urinary retention, what we call difficulties with voiding. So the bladder is more than just a bag, a muscular bag of urine, and anyone who's had bladder symptoms from a neurological problem knows that to be the case. So what happens is the bladder, all the way down the bottom here, as it fills, signals of it filling is sent up the brain to the brain via the spinal cord. So it comes from the bladder up through the pelvic and pudendal nerves up into the spinal cord and travels all the way up to the main areas being in the midbrain, and also relies on signals from the front part of our brains, which tell us is now the right time to empty my bladder. Now, the bladder holds up to half a litre of urine normally, and it empties 4 to 7 times over a 24-hour period. And either no urination is passed at night up to once at night. This is what's kind of normal bladder capacity and frequency of urination. And typically, on average, people pass 1.5 litres in 24 hours. So when we're thinking about bladder symptoms, we're thinking about 2 different groups of symptoms. And firstly, what we call the storage symptoms or overactive bladder symptoms. And these are the symptoms people get when the bladder muscle, the detrusor, is often overactive. So the muscle is contracting more than it would be. And in time, that muscle can become underactive because it has had a long time of overactivity and contracting more than it should be. And the muscle starts to become thinner and less strong at contracting. So the storage symptoms that we ask people about are urgency. So that is when you have the urge to go to the toilet, are you able to hold on, or do you need to go immediately? Frequencies, that's how many times during the day and night you pass urine. Nocturia, how many times at night? And incontinence. So are there any times where you have difficulty holding on to the urine and may have passed some urine unintentionally or have some leaking? And we call it urinary urge incontinence when it's associated with urgency, as opposed to stress urinary incontinence, which is when people have some leaking of urine when they cough, sneeze, laugh, which is more related to the pelvic floor. The second group of symptoms is what we call voiding symptoms, and that is when the kind of act of emptying the bladder, and is there any difficulty with emptying the bladder once the urine leaves the bladder and out through the urethra. So the sort of symptoms we ask about here: is there any hesitancy? Do you need to sit down on the toilet to pass urine? It takes a bit of time for the pee to start. Do you strain? Do you need to push a little or strain to get the stream of urine started? Is the flow of urine interrupted in any way? By that, is it a steady flowing stream, or does it tend to stop and start? And lastly, double voiding. So when you've finished urination and you leave the bathroom, do you need to return within 5 or 10 minutes to pass urine again? So these are some of the questions that we start off when we're assessing someone who has bladder symptoms. So we want to first understand, do you have mainly storage symptoms or voiding symptoms, or a combination of the two? We will often check the urine for an infection. And then importantly, we want to understand is, does the bladder empty after urination? And we look at this using a uroflowometry, and that's like an electric commode chair where we can measure the volume of urination, the speed of urination, both average and the peak speed of the flow as well. And then after that, we use a bladder scan to see if you've emptied the bladder or if there's some urine left behind. We ask people to keep a diary at home, and usually that's over 3 days to give a kind of a good view over several days, looking at when you pass urine and what volumes of urine. And that's your output, and then on the input, what and when you are drinking. So what volume and when you drink. So the easiest way to do that is to use a measuring jug. Sometimes we'll do more advanced testing like urodynamic testing, where we look at the bladder structure and function. And so that looks at the detrusor muscle, the bladder muscle. Is it, what capacity do people have in terms of being able to hold urine? What's the bladder muscle compliance like? Is it as stretchy as we would expect, or is there reduced compliance? We look at if there's overactivity or bladder muscle underactivity. And then we look to see if at what stage and what volumes people have some urgency, and if there's any urge incontinence and also stress incontinence. And then following that, once we have an overview of someone's bladder function, what are their main symptoms and issues, and also them as an individual, we talk about what is the best treatment and way to manage bladder symptoms. So this here is the way we measure for a bladder scan. So it's similar to the ultrasound you'd have for an obstetric during pregnancy. And what we're looking for is how much urine is left behind. So anything less than 100 mils, we're not too concerned about because that's normal. More than 100 mils of urine left in the bladder is when we would consider a different management pathway. And that would be more geared towards assisting the emptying of that bladder, which is different for different people, but often means teaching someone how to self-catheterize. And the reason we wish to keep the residual urine in the bladder below 100 mils is because anything more than that can cause some increased pressure in the bladder and flow back up towards the kidneys. And if that happens over a long period of time, it can cause kidney damage. The other concern with a high, what we call post-void residual, so more than 100 mils in the bladder, is that it also puts people at higher risk of urine infection because there is a stale pool of urine, and that is an ideal environment for bacteria to live in, which can cause urinary infection. So in terms of more practical aspects of managing the bladder, I'm going to run over several things, some general measures, including pelvic floor exercises and bladder retraining. And then in the second part of the management section of this talk, I'm going to talk about medications for overactive bladder and other non-pharmacological ways we have of helping to treat overactive bladder symptoms, and some of the catheters and other appliances. So in terms of general measures, the first thing is fluid intake, and this is really individualized, and this is where a bladder diary is really helpful. So generally we recommend people drink between 1.5 and 2 litres a day, and avoiding certain drinks which are irritant to the bladder. So that's caffeine, so switching to decaffeinated tea or coffee, avoiding alcohol, citrus fruit juices, and sparkling drinks, cola, sodas, anything with bubbles in it, and that includes sparkling water. So it's the bubbles and caffeine which really irritate the bladder. The other thing I'd just like to draw your attention to is this radar key scheme, which is actually, the radar is a company name. You can find other key schemes if you look on the internet, and that's priority access to UK accessible toilets. So for a small fee, you can purchase one of these keys and then have greater access to toilets. And I know that's been really difficult during the pandemic, with some of these toilets being closed, but hopefully things are now improving again with access. And some other general measures, depending on your needs, rails to help with sitting to standing from the toilet, raised toilet seat, commode chairs, and then some really practical things, such as if you have a lot of urgency and it's quite difficult with trousers, etc., some modifications that some people find helpful, using Velcro rather than a zip. So bladder retraining, the aim is to teach you how to control your bladder instead of your bladder controlling you. And part of it is avoiding that just in case going to the toilet before you head out. So how to start doing this and how to start retraining your bladder is when you feel the urge to wait for 5 minutes initially, and then after 5 minutes where you've distracted yourself, and then passing urine, and doing that for 1 week, waiting for 5 minutes. And it may be initially it's 1 minute or 2 minutes, but whatever you can manage, and then doing that for 1 week, and then at the end of that week, increasing by 1 or 2 minutes, and then gradually increasing week on week until you can hold on for a longer length of time and you feel that you're more in control of when you need to pass urine. Other people do bladder scheduling, so they void on the clock. And this is particularly if people have more difficulty with emptying the bladder. So they might, every 2 to 3 hours, they have an alarm on the phone where they make sure they go and empty the bladder at that time. So pelvic floor exercises, and you can see here, this is the bony bits in the pelvis, and the muscles and ligaments here form a sling. And it's almost like a hammock of muscles and ligaments which support the abdominal and pelvic organs. It helps the urethra to stay closed when you cough, sneeze, laugh, or if there's anything else that increases your abdominal pressure. It helps to control wind and bowel motions. And most importantly, it's for men and women. So pelvic floor exercises are important for men and women. And I've just put on the page here, there are 2 PDFs that people can follow, and also the Squeezy app, which is developed by NHS pelvic physiotherapists. And they have developed this app which details different pelvic floor exercises. So I'd also recommend that. So other people develop their own methods of abdominal stimulation and triggers. And some people find rubbing their abdomen to be helpful to kind of trigger themselves to pass urine. Other people find standing up, then sitting down again can help, because and certainly if something people often complain of is they stand up and then they pass a bit more urine. So kind of getting into a routine and finding what works for you is before you reclothe yourself and get ready to leave the bathroom, stand up, then sit back down again. And sometimes you can pass a little more urine in that way. Other people find kind of rocking on the toilet helpful. Other people do the double void at the toilet. So they'll just wait a bit longer after they've finished, and knowing that after a couple of minutes, they often pass a little more urine. I mean, some, in terms of other ways of triggering, some touching the urethra for women, they find that can be triggering, and for men, a gentle tug on the penis can also be a trigger for passing urine. Now, the Queen Square Bladder Stimulator has been around for a number of years, and some people find it particularly helpful if they have difficulty with hesitancy. So it takes a little bit of time and they have to wait for the flow of urine to start. And also if they have trouble with emptying the bladder, so they have some voiding difficulties, that is kind of the group of people who find the Queen Square Bladder Stimulator to be helpful. So now we're going to talk about some other aspects of management. And some of these aspects is where it's really individualized, and it depends on if you spend much of the day out of the house, at work, etc., or if you spend much of the day where you are more limited in how you move around. Do you need help with doing toileting tasks, eyesight, the dexterity of their hands can have some implication if a catheter is needed as well. So all of these individualistic criteria are taken into account when considering the best plan for you. So first I've just got some images here of what we call containment products. And you can see on the left here, if I can find my mouse again, is the sheaths or convenes. The convene is actually a brand name, but it's commonly used when talking about a sheath, which is like a condom that goes over the penis and then is attached to a bag and captures urine. So it's important to note that one size does not fit all for the sheaths, and it's really important to have the correct size. The tape here is a stretchy tape, And it's really important, if you do have the wrong size or if you find it's falling off, to never tape the sheath on, because that can cause tearing or skin damage. So it's really important that if you find the sheath is falling off, that you're resized, you have the correct size. And on the right here, we have different pad products, with the slightly bulkier product on the right down to the slimmer products. And as Colette often says, in terms of the catheters or the pads or the convene, it's only as good as it's placed or sized. So if it's the wrong pad size or the wrong pad absorbency, then it's not going to work for you. So all of the CCG are different in terms of the pad type they provide, the number that are funded, etc. So it is very different depending on where you live in your CCG. So in general terms, what can be useful is to use the more kind of hospital, thicker size pad while you're at home, and use the smaller, slimmer products when you're out and about. So I've just put this up again because before we talk about the catheters, because the catheters we look at when people have difficulty emptying the bladder, such as they have a high post-void residual, and also for other reasons as well, if people have a lot of incontinence, which is very uncomfortable and can affect the skin as well. Those are reasons as well to consider catheterization. And also, the bladder scan is also important before we look at tablet treatment for overactive bladder symptoms. And people need to have less than 100 mils of urine in the bladder to start tablet treatment if they're not using a catheter. And the reason for that is if you have, say, for example, 200 mils left behind in the bladder, the way the tablets work is to relax the bladder further, so it'll make it more difficult for you to pass urine. So you can see here there are quite a number of different medications. And we tend not to use oxybutynin as much these days because it has been shown to affect memory in some people over a long period of time. So we prefer to use some of the more modern antimuscarinic medications, and which we choose really depends on an individual. So if people do have some more problems with their memory or thinking, we might move more towards trospium and darafenacin, as opposed to some of the other choices. What they all have in common is that they commonly cause dry mouth and dry eyes and can worsen constipation. And really the main thing to be aware of is if you've glaucoma or untreated glaucoma, then that would be a contraindication to starting an antimuscarinic. And if people can't tolerate an antimuscarinic for various reasons, then there is mirabegron as well, which is in a different family of medication called beta-3 agonist. And that can be useful, particularly if constipation is very difficult to manage. Other non-tablet-based treatment is what we call tibial nerve stimulation. So the tibial nerve rests behind the ankle bone here and travels up the back of the leg, the back of the thigh, and into the bottom of the spinal cord through the sacral nerve roots. And what we know is giving some electrical stimulation at the tibial nerve interrupts the reflex arc up at the sacral nerve roots and interrupts the signal coming out of the sacral nerve roots down to the bladder. And so about 60% of people with electrical stimulation of the tibial nerve over time will have a reduction in their urinary urgency, urinary frequency, and incontinence. We can give it in two ways. The first is using an acupuncture needle, like you can see here, a slim acupuncture needle. And the second way is using these sticker electrodes. And the sticker electrodes can also be done in your own home. Another treatment option that is available under, depending on certain circumstances, is Botox for the bladder. So similar to the face where it relaxes facial muscles, Botox for the bladder relaxes the bladder muscle. And you can see multiple injections of Botox are made over the bladder. And it's inserted via a flexible tube called a cystoscopy that goes up the urethra. And what comes out the end of it is the needle for the Botox. So it's quite fast, it's done local, and the effect lasts typically somewhere between 6 and 10 to 11 months. People do need to know how to use a catheter before undergoing Botox, because about 10% of people need to use a catheter to help to empty the bladder as the bladder muscles relax until the Botox wears off. So this brings us to the next section of the talk, which is talking about catheterization and intermittent self-catheterization. So that is when people are emptying their bladder themselves using a single-use catheter, which is inserted in the urethra into the bladder. The bladder is drained, and then the catheter is disposed of. And people catheterize anywhere from once a day up to 7 times a day, depending on what their requirements are. And you can see there's a wide variety of choice here and different bags that can be attached as well. So there are lots of different options depending on what your requirements are. The other option for permanent catheterization is a catheter that's there all the time. So it's not intermittent, it's permanent. And this can be placed in 2 ways, either urethral, so that's a catheter where the tube goes up the urethra, or what we call suprapubic. So that's where the catheter is inserted with during a day procedure into the skin below the belly button, then through the skin and then into the bladder. And really the choice of that depends on the person and what they prefer. Generally, for the long term, we prefer suprapubic catheters simply because there are less issues with the urethra becoming uncomfortable with having a catheter there all the time. And the sorts of people who might be thinking about having a permanent catheter is they may have had tablet treatment, they may have had tibial nerve stimulation but still find, and maybe Botox, still find they have a lot of symptoms of overactive bladder, and they have difficulty emptying the bladder and have been unable to, or found it difficult to manage with an intermittent catheterization. In terms of the suitability of long-term catheters, so in the long term, they're not latex generally, and there are different lengths. And some people prefer, so this top catheter is the female catheter, the bottom catheter is the male catheter. So some people prefer having a longer catheter is the same length as the male catheter, so there's more room for the bag and less likely to get caught around with clothes, etc. They typically stay in for 12 weeks and they get changed 12 weekly, sometimes might be changed more frequently. And if there are other issues with the catheter some people experience, such as debris, bladder stones, then depending on the issue, there are a number of maintenance solutions which are available to instill into the bladder and help to deal with debris or recurrent infections, etc. Another issue which can happen is something called urine bypassing due to bladder spasm. So that's when the bladder is spasming and urine comes out alongside the catheter. And so that's where it's important, particularly if you've been on overactive bladder medication, to stay on it when the catheter goes in, because particularly around the time when the catheter first goes in, more likely to have some bypassing around that time and bladder spasm around that time as you get used to the catheter. And also at other times beyond that, if urine bypassing is occurring, that can also be treated with bladder Botox as well. There are a variety of bags and valves, and different bags depending on what you want. So night bags, there can be bags that come around like a belt, and the valves on this other side here is good to kind of maintain tone of the bladder. And usually we start building up from about 30 minutes a day, and that might be 15 minutes a morning and 15 minutes a night. And this is unless there are infections. It also helps to, if you are using the flip flow valve or using the valve, it does help to clear sediment and clean the tip rather than the bladder being on full drainage all the time. So to recap, bladder symptoms are very common, and one of the important things to check is that the bladder is emptying, and then treatment is really individualized based on what your problem is, and then what is going to be the best way to resolve those symptoms. The sort of things that can be done immediately at home: checking your fluid intake, making sure you're not drinking too much coffee or tea, starting pelvic floor exercises. And the thing about pelvic floor exercises, they need to be done every day, and it will be months before you start to get some benefit. So it really is kind of the long-term game with the pelvic floor exercise. Do them when you're brushing your teeth every night, and start to see some results in several months. And then we've also talked about some treatment options, including the pill side of things with overactive bladder pills, antimuscarinics and mirabegron, and also the electrical stimulation of nerves as well as bladder Botox. So I've just added an extra slide in here, which if we've run out of time can be paused. But I just wanted to briefly talk about urinary tract infections, because some people can have recurrent urinary tract infections, so more than 2 or 3 urine infections in a year. And they can lead to worsening of your symptoms and generally, make you feel unwell. So the first question is always, is there a cause for the urine infection? And the sort of common things that can cause infection are not emptying the bladder completely. Sometimes people can have kidney stones, and if the kidney stone's in a certain place, it can obstruct the flow of urine and can cause urine infection. And then the important thing to think about next is, what is the bacteria? Because there is a non-prescribed treatment called D-mannose, which can be obtained from health food shops. And we've found it to be very effective for urine infections caused by E. coli. And it's a urinary antiseptic. It's something you take every day as a preventative. Other options of urinary antiseptic preventatives, methenamine hippurate or Hiprex, and that's particularly useful for non-E. coli urine infections. And then sometimes when people have tried both of those urinary antiseptics, they do need to take some long-term prophylactic low-dose antibiotics once a day, and those need to be changed regularly on a 3 to 4 month basis, depending on what your urine is sensitive to. Thank you very much for listening today, and I look forward to taking questions.